Y'all, you're getting close, Marcus. No.
No, I was just saying green space.
Green space is helpful, but it's a little bit more elementary than that. Sidewalks. That's one.
Okay.
And the next one.
Bike lanes.
Nope, not bike lanes.
Crosswalks.
Nope.
Is it lighting?
Lights. Putting up a street light and building a sidewalk will drastically decrease crime and violence in a community.
Wow. Is it because it makes it feel structured? And
so broken windows theory might tell us that a sidewalk with streets and lights may make us feel like, oh, this might not be a space where I need to like throw my trash on the ground.
Right.
One might go that way. It's really just the fact that someone won't typically bother you if they feel like they can get called. When we look at crime opportunity, one thing I've enjoyed about my public health career is how I've been able to like have my hands on like so many different like issues, so violence and reproductive health and HIV. So when we look at crime, it's about opportunity. It's real. Well, it's also now sexual violence is also about power. So I know, look, some folks, it doesn't matter where they are. If they try to do it, but and I don't want to necessarily say that streetlights and sidewalks will eliminate crime. It will drastically decrease it because it decreases the opportunities. And not even just when it comes to sexual violence, when it comes to a lot of different violent crimes that we find. Now, fundamentally, it's streetlights and sidewalks. And we think about cameras and we think about other infrastructure things, so community safety plans. Like there are neighborhoods that develop non-police centered safety measures. And not to go into this rabbit hole, but I oftentimes have this growing consternation of many communities not understanding non-alternative policing strategies because they are already being implemented in communities already. We call them neighborhood watch. We have infrastructures to ensure safety that already exists. So at Georgia Tech, one of the things we did was we just put up call buttons in lit sidewalk areas in case someone had an emergency. And it didn't even have to deal with sexual violence or anything related to violence. I'm lost and don't know where to go, and it's 2 o'clock in the morning, and quite honestly, I'm lost because I'm drunk.
Mm-hmm. I was gonna say, and with the sidewalks and the built community or whatever, I wonder if it also plays a part where when you see sidewalks going up, or you see bike lanes, or you see trees, or whatever, and those different things that the city or the built community, the municipality is in charge of, it kind of says, oh, these people see me, they care, and it kind of it can help change
the psychology
and shift. Yeah, because so for instance, back home in North Carolina, like the city I grew up in, because it is gentrifying, sidewalks are going up in places where near the church I go to. It's never been sidewalks, never been trails, and now all of a sudden, because a population of people are starting to move in, now these different amenities that should have been there before are there now, and I'm just amazed. And so I wonder if that shift even you see me because you're putting up these lights, you have this park for me or whatnot.
You literally see me because there's a light.
Yeah, right, for sure.
Right. So tying this back to HIV, my thought has been that's so simple, that's so easy. So what are we overthinking HIV prevention? Are we overthinking STI prevention? What are the simple ways that we can do to change?
I think we are.
It was a thought-provoking addition to the conversation.
No, I appreciate that. Oh my goodness. Okay, y'all, I gotta.
Sorry.
Okay, go ahead.
I'm sorry. Can I ask you a question?
This is
and
good.
See if this can be added into the conversation, because as we're talking about these pillars, right, that affect that are social determinants, not all of these can be used or applied to our brothers and sisters who are incarcerated, and that's my heart. My heart is there, and there's a lot of our brothers and sisters who are not seen, right? That look like us.
Yeah.
And so it's not necessarily a matter of creating a safe space by building sidewalk.
Yeah.
But I just want to incorporate that into the conversation some.
But even so, I will go to our social and community context, because when I was growing up, churches had prison ministries.
Right.
We were writing letters to folks we know who they were. We were visiting. I heard this one sermon, is your name on the visitor's log, where the pastor was talking about the text where Jesus is saying, when I was in prison, you visited me. Literally, and then all throughout Acts, we have all these stories of people in prison because of preaching the gospel, but in prison and being visited by either God or somebody else. Somebody writing a letter to him. Paul literally in prison, right? So within at least our biblical infrastructure, there is this mandate towards prison ministry, and I know historically churches have done that because that could provide us access to be now worthy of a street light, that's deemed worthy of a visit, that's deemed worthy of our outside of the policing institutions advocacy for the resources that they need. One of the things I think about with American history is our fundamental question is who's a human? And our next question is who's a citizen? That has been the animating question of this American project forever, and that is a social and community context question. Who is a human? Is a slave a human or are they not? Is an immigrant a human or are they not? Is a woman a human or is she not? Are trans people human or are they? Like this question of who is a human has animated our social and community context. And if we say that prisoners are human and are worthy of rights, despite what the 13th Amendment might say in regards to them basically being brought back into slavery, how might that inform our decision making?
Exactly.
So yes, I really thank you for raising that and raise those questions. So hey, I don't have a lot of time, but I want to go through 4 considerations when thinking about social determinants of health. Consideration number 1, social determinants of health are macro language to explain macro outcomes, not define micro circumstances. There's a lot of words there. Macro language to explain macro outcomes. Public health professionals use social determinants of health to understand why do we see certain trends in communities, in neighborhoods, in states, in countries. And one of my chagrins is that we oftentimes use the language to describe those social and sometimes community issues to then define and pigeonhole the individual. So we tell the individual's narrative based on social language, and the individual's narrative is never heard. And I think oftentimes in many of our community organizations, because we have so deeply shaped that person as being poor, as being black, as being from X, Y, and Z, we don't actually hear how many of that language has shaped their own individual narrative. And so we give them prescriptions for a macro situation when they need very individualized, circumstantial forms of care and treatment. And so one of the first things that I always get so frustrated about is when I hear people talking about social determinants when talking about an individual, and I never hear the individual's narrative in any part of that discussion. So my first thing I want you to consider is to never talk about social determinants if you do not know that person's narrative. Talk about it if you know if you talk about community. Talk about it if you talk about a state. Talk about it if you talk about a region. Don't talk about it if you don't know the narrative of the individual you are in direct relationship to provide services to. Because what that does is, one, it causes us to have too many assumptions and too many make assumptions, and this is why I use my iPad. But it causes us to make too many assumptions and generalize. Yeah, there we go.
Can you give us an example so that we can walk responsibly with our language? Can you give us an example of that?
Yeah, so so for instance, in Atlanta, when we would do linkage to care, we would have conversations with the person about their different social circumstances and contexts. And then in a care meeting is basically where we have a variety of stakeholders at the table to talk about a treatment plan or a plan of being able to help that person. All we are talking about in regards to that person are all of their social identities. so we talk about them being gay, we talk about them being black, we talk about their income status, we talk about what area of town they live in, we talk about all of these things that are on our particular intake forms, but we never ask a question of, okay, what brought you to Atlanta? And then, how does what brought you to Atlanta inform this care meeting? Because if what brought you to Atlanta is trauma, running away from a pastor who sent you to hell, and so you had to run. And if we don't have that particular narrative part within our discussion, we will never know that if we don't help this person with their trauma and their mental health, giving them a pill will never be successful. Yes, or just the full picture. Right. Just the social determinants oftentimes are just quick and easy things that we result to because we want a quick and easy way of understanding the person.
Mm-hmm.
And so,
oh my goodness.
Yes, go ahead.
During COVID, our church wanted to give food to a food insecure neighborhood that was in where our church is located. And so we were giving out cans of food, and one day we took the time to actually talk to a participant who was receiving the food, and they didn't have a can opener. So while we meant well, while we wanted to, but a simple conversation just asking what is it that you need, it served us a lot less time in addressing the individual need rather than us spending a lot of time and money and effort providing things. Well-meaning, right? Well-meaning, but not taking care of what the actual need is. Sorry.
Go ahead, Marcus.
No,
I'm getting happy now.
Just thinking about that, like just some of the work, just being in public health, I think, and research specifically, like that was one of the things that used to tear my nerves up because it was like we go in. So the first project I worked on, we were community participatory research. And so like we actually formed a board of people from the community, scientists, researchers, all that stuff. And we wanted to get feedback from the community. Some of the other projects I've worked on have been more traditional research where we say they kind of go in, get what they need, and then they leave. So like they're like raping the community. We call it raping the community. And it is this idea, and I think that sometimes we have taken it on because of the structure of the systems that we work in, that we believe that we have all the knowledge. The community has the knowledge to heal themselves and can tell you, but we have to give them the avenues. We may have the resources or access to the resources, but like they can heal themselves. Like I've had conversations with people who grew up in the quote unquote hood, and they're like, oh, I know what to do. I know why the crime is so bad because gentrification is pushing these two neighborhoods that normally wouldn't be in the same neighborhood together.
Yeah.
And so now,
and to the point that you were raising earlier around systems, that is our, and I'm gonna use maturity language, that is our call to remake systems so that people can utilize those remade systems to heal themselves, right? To really reshape our healthcare infrastructure so that people have the access to know how to tap into those resources to get the healing that they need. So second point of consideration, money in medicine ain't enough. What do I mean by that? America spends per capita the most money on healthcare than any other developed nation. But when we look at all of our statistics, we are not coming out on top. Our money has not materialized into actual positive healthcare outcomes. We are not doing well. Another example of that is when we looked at so I am admittedly shamed without any sense of, oh, you gotta go.
No, you keep going, I'm gonna go talk.
Okay. I am admittedly and unashamedly a proponent of Medicaid expansion. Georgia is one of the states that has not done that. But even with Medicaid expansion, we have a test to see whether or not it actually solves the issue. Unfortunately, it does not. While expansions of Medicaid, maternity care around 1990 resulted in increased receipt of prenatal care for African American women, racial disparities in key birth outcomes of low birth weight and preterm delivery were not reduced. So more people access prenatal care because of the expansion of Medicaid, but the results still didn't change. And so it's like, dang, what's going on? Although important for maternal health, traditional clinical prenatal care generally has not shown to improve outcomes of newborns.
It goes back to what you said earlier. One of the systems of education. There's certain things we don't even have and know how to take care of our bodies. And naturally when a black woman, when I found out I was pregnant with my black son, who you probably saw yesterday dancing
Catching
around.
the Holy Spirit, yes.
And I brought him intentionally.
Yes.
Because he's a part of this conversation.
Absolutely.
This is our story.
Absolutely.
Okay? When I found out I was pregnant, the first thing was not, oh, I'm so excited. Yes, life's gonna be great. The stress went right on my shoulders. My stomach turned. The fear set in. That was already there.
Yes.
It grew.
Yes.
So yeah, we have
Preeclampsia is like through the roof.
I had it.
Yes.
I was
yes.
at
Like I
UCLA.
don't like low
Great
key. I
memory.
don't know anybody that's birthed over within my adulthood life that hasn't, and that is frightening.
It's frightening.
That is frightening. That is frightening. Socioeconomic factors have found that racial and ethnic differences were substantially reduced. So like the higher you went up in your income, the issues related to race. Well, okay, I'll say this. When we look at black people and white people and Hispanics who are millionaires, oftentimes the racial health disparities can oftentimes oftentimes the health disparities can look kind of flat. They're all millionaires. They're all probably accessing healthcare. But once again, money and medicine ain't enough if we aren't addressing our racial infrastructure. This flatlining of millionaires across racial lines does not imply that only differences in experiences between racial and ethnic groups are socioeconomic. Racial discrimination could harm the health of individuals of all socioeconomic levels by acting as pervasive stressors in social interactions, even in the absence of anyone's conscious intent to discriminate. Furthermore, the black and white disparities in birth outcomes is largest among highly educated black women. Living in a society with a strong legacy of racial discrimination could damage health through psychobiological pathways, even without overtly discriminatory incidents.
The psychosocial, yeah.
Exactly. So I tell people all the time, medicine and money ain't enough. It's not enough. Am I saying that don't pass that apportionment bill? That is not what I'm saying. I'm saying if we are not intentional about how we then utilize those dollars in strategic and intentional ways, we will not achieve our healthcare outcomes, because it's not just about giving folks money. And it's not just about opening up a new clinic. Because if I walk into that clinic and that clinic does not honor the fact that I use she, her pronouns or they, them pronouns, I'm turning right back around. And that is a worthy reason to have frustrations around.
Yes.
Because that community has decided that the fullness of your humanity is not honored and welcomed here. And so if that part is not welcome, then what other parts of my story that I will share as a part of my healthcare experience will also be ignored.
Right.
All of that matters. Third point of consideration. Most public health researchers have only answered questions that prove that prove that there are relationships, but we still don't know how factors fully relate. So, what am I saying? Are there factors in our society that impact healthcare outcomes? Yes, that is saying that there is a clearly defined relationship. There's a factor, and I can draw a direct line to say it connects to an outcome. But what we are also realizing is that there is an entire network of factors. And one of our challenges and one of the additional chagrins that I have when I hear social determinants of health is that we don't fully know how all of these factors relate. A lot of the research to come to those conclusions are just really difficult to do. A lot of socioeconomic factors are because of generational things. The longitudinal studies necessary to do generational research is incredibly difficult. And look, you might have that one principal investigator that's been at the institution 20 years, but their team of researchers will so greatly shift, and God knows how that's going to impact data collection, analysis, writing, like all of that. So we don't know fully the full picture of how all of the factors impacting people's health outcomes are relating to each other. And the research to do that is incredibly difficult. So, I say that to say, a lot of what I hear in terms of people talking about, oh, well, it's this, I'm oftentimes like, is it? Oh, because no one's actually empirically come to that conclusion. And so, I always get a little frustrated by that. All right, so the fourth consideration I want folks to do is define your lane and not stay in it, build an interstate. What I mean is this. Find the lane within these pathways of social determinants that you best drive in. And you know how, typically we say find your lane and stay in it. Find your lane and then connect your lane with other lanes, and we will have an entire new interstate, which will be our new healthcare infrastructure. Y'all, if we build the problems, we can dismantle them and build solutions. Is it going to take some sacrifice? Yeah. Is it going to take a lot of money? Yeah. But guess what? If we found our lane, I know my lane. I love public health. It is a huge part of how I navigate the world, but I know I am most fundamentally a minister. My lane is ministry. My lane is not being a professor at an institution. My lane was not really in like HIV treatment and care. my lane is in a pulpit. I know myself. I know how I best show up in the world. And I bring that, but what I do is I connect my lane with a professor's lane, with a linkage coordinator's lane, with a state a lobbyist in the lane, and we put all of our lanes together. And all of these complexities that we're saying regarding social determinants of health become so much easily addressed because we don't have to feel like we need to do it alone. So I had another untested hypothesis that I wanted us to play around with, but we have no time to do it. But I was going to throw out just this, like I said, untested hypothesis. Social determinants impact more of the success of who maintains viral suppression than who does or does not contract HIV. I just want you to sit with that for a moment. Do you understand what the claim is? Whether you agree with it or not?
Is it saying someone who receives?
What'd you say?
I don't think the social determinants of health actually does both.
Yes. Yes. The hypothesis is more.
Are you saying that focusing on the social determinants too much, isn't effective?
Not necessarily. What I'm saying is, I think when we oftentimes think of many of the social determinants that we've discussed in this room, access to healthcare, education, cultural and social context, our environments, the claim is that those metrics impact who can maintain viral suppression more than who is vulnerable to contracting HIV. Now, there is a relationship between viral suppression and transmission. We have the famous language U equals U. And so my argument that I am struggling through and thinking through and wondering if I'm right or wrong, or a limb that I'm willing to. Well, good thing about going to college, you throw out ideas and you bounce them around and see what sticks. My argument is that if we do a deep analysis of our social determinants and apply the conclusions of those analyses to people who are working to achieve viral suppression, to address their the issues impacting the outcome of whether or not they can access the treatment necessary to achieve viral suppression, that will drastically do so much of the work in our efforts to curtail the virus.
I was at a conference one time and I heard the statement that Black people are more likely to contract HIV. No, sorry. So poor people are more likely to have HIV and Black people are more likely to be poor. So that's why our numbers are the way they do. And this is what that says to me. That because of those social determinants of health, we're poor, right? Like our socioeconomic status looks different.
Yeah.
And because of that, we're more likely. And I think that all ties into food insecurities, housing, criminal justice system, education, and all of those things.
Yeah. I'm not saying this is right or wrong. I'm struggling with it.
If you really sit here and think about that, because our numbers are increasing. So that, whatever going to U equals U drop, then that means that the infection is still there. So what is the impact as to why the viral load, why there is not suppression?
I just want to jump out and say, I think our focus needs to be on getting folks virally suppressed. I'm all here for efforts to get folks on PrEP. I am not. I don't want to say that. Okay, it's afraid we throw out statements like that. But I think our answer is viral suppression. I truly do. I truly do. All right, y'all. I was going to tell y'all this. I had this really cool analogy around rocks and stuff, but it's so irrelevant now. Here's my contact information. If you all want to reach out to me, you all can find me on Facebook at just typing the Unches one way. Y'all can send me a Facebook Messenger thing. I'm fine with that. And there's my emails. This is my church email. This is my personal email. I'm accessible through both. And yeah, y'all have to go because
Just want to let y'all know lunch is being served in the junior bar.
already.
Yes,
And these are my sources because I don't believe in providing information I can't back up. But thank you all so much. It's been an enjoyable discussion.
Right, will you be taking, I know that they said that we can schedule times with people to have.
Oh, you
prayer
can?
conference. You're like, I don't know that I have time.
Sure, I mean, just let me know. 5 years. I can talk about this stuff all day. So.
That's good.
Yeah, this was really good.